Okay guys, good morning. Welcome to the Thursday simulation sessions. So today the simulations will be run, the participants would be the consultants. We've got Dr. Ryan here, Dr. Reade and Dr. Khamoudes. So our basic assumption here is that everyone participating in training is obviously intelligent, capable, does their best, and they do it to improve. Alright? Basic assumption. Alright? I will give the rest to Jamie, which will do the pre-brief. And also, just to double check, has everyone filled up the consent form?
No.
Okay.
I'll give you my consent and I will fill it in and give it to you. Okay.
I'll get you to do that after this. Okay, very good. So the video will actually be uploaded, but it will be uploaded via a link on YouTube. But only those people who have the link will actually be able to view the video. It's not searchable otherwise. So for those of you here, don't go around sharing the view to the general public or whatsoever. It's only for us staff. Is that alright? Perfect. Very good. Jamie.
Okay, so this is the hypothermia near drowning case.
Before we start, can I ask, can we get some gloves? Are the gloves in here?
There should be
No,
them
they're
running
taking
around.
gloves. Could you get some maybe 2 aprons and 2 gloves as well first? Thanks. 3. Sorry, 3 gloves and 3 aprons. 3.
Yeah, is that okay? So the hypothermia near drowning case, we have a 6-year-old boy who was out boating with his father when the small boat inadvertently hit a large wave and flipped over. The child was not wearing a life jacket. The father survived and swam with the unconscious child to the shore. CPR was initiated on scene and an ambulance was called. On arrival, the paramedics noted the child was apneic, pulseless, and cyanotic. CPR was initiated by the paramedics with bag valve ventilation and a C-collar was applied. The child was brought to the ED by paramedics with CPR in progress. And Trina's nurse straight to recess.
So just recap, 6-year-old boy, boating accident, not wearing a life jacket, submerged underwater, father brought him to shore, he's been unresponsive, and he's receiving CPR on the back of the ambulance. Okay. Get some gloves and an apron and pop in here.
She tried to bring my stethoscope.
Neither did I. Oh, borrow. Elysha, go borrow your stethoscope.
Yeah, you can.
In the office.
So, do you want to run it?
Yeah, sure. Perfect.
Sorry, and CPR is in progress.
Yeah, it's been going on for 10 minutes prior to arrival.
So, does somebody want to be the, do you want to, Tracy?
Thank you.
Have you decided who wants to go in first?
Again, just to reinforce that everybody, we would be wearing kind of FFP2 and full gowns and eye protection, considering this is a resuscitation, but in the interest of preserving resources, just wearing aprons and masks.
The meeting. I'll grab the meeting host for you there. I know you'll be small. Thank you so much. Maybe this one will get here. Yes. Oh, that one's the net part from first.
So Dan's gonna come in last, right? So for this Dan, let's see if you can sit here. Very nice.
Great stuff, thank you.
Sit.
Okay.
I think you're inside at the start with me.
Oh, am I?
Okay.
So receiving the patient?
Yeah.
Receiving the patient.
So, hello, hi guys.
Hi.
Are you the doctors?
Yeah.
We're doctors here.
Okay.
Hi.
So sorry, I'm actually a new paramedic. So we've got a 6-year-old boy here that was on his boating trip with his dad. All right. He actually got thrown off the boat. The dad jumped in and took him out, and they came to shore. All right. Since then, the dad has actually started CPR. All right, and he's called the ambulance. There was an ambulance nearby. There was 2 minutes, and then we came and we continued CPR. So this is him. For as much as we know, he doesn't have any past medical history, but that's all we know. Is that okay?
Yeah.
Okay, just behind you.
Want to take over, please?
Will I take this over here?
Yeah.
Thank
And
you.
we'll take off all the wet coats
Okay.
as well.
2, 3, 4, 5.
That's what we've got. And can we get some help
Back
for
in
you
the chest.
guys? So Tracy,
1,
could
2,
you...
3, 4, 5, 6, 7.
And is there any more help that will be coming
Can
in?
somebody
Would you
get
be
the
able to
airway?
call the
Can
anaesthetic?
somebody get the airway as well for me?
And yeah, if you would mind, I can do the airway.
You
Do
do
you
the
want to
airway.
set up the monitors?
If you do the airway and all the chest compressions, and then Tracy, will you put out the 2222, get Pete's resus urgently here. Crash call.
Call to read
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2.
Tracy, we need to bring your mask as well for when you get a chance. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 13, 14, 15.
One,
Can we get a bigger mass,
two.
guys? 1, 2, 3,
Someone is getting
4,
a bigger mass now.
6, 7, 8, 9, 10,
And
11,
anyone else
12,
gonna come in
13,
and help
14,
us?
15. We need another pair of hands, guys, please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2.
Can we get a bigger mass, guys, please? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2.
Can we get a scissors as well to that close up? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2.
1, 2, 3, 4, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 1, 2, 3, 4, 5, 6, 7, 8, 9, 12, 13, 14, 15.
1, 2. Do you need to
1,
swap over
2,
soon?
3, 4, 5, 6,
Maybe after
7,
this
8, 9, 10, 11, 12, 13, 14, 15.
1, 2.
1, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1,
We need a
2.
scissors, guys.
Yeah,
We need a pop
big banded
scissors.
scissors.
Please,
Banded
yeah.
scissors.
1, 2, 3,
It's crap.
6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2.
Can somebody call anesthetic? 1, 2, 3, 4, 5, 6, 7, 8, 10, 11, 12, 13, 14, 15.
Hi guys, Danny, the consultant.
Hi, Dan.
Hi, Dan.
How can I help?
We have a 6-year-old boy with a submersion. He was in a boat, fell off the boat was knocked over. 1, 2, 6 years of age. He came in, dad brought him ashore for CPR, came in with ambulance, CPR has a neck brace on, CSAN section. On CPR is ongoing, we're just giving him one dose. We need more people to do IV access, so we can start IV
Are the
access.
access not a problem?
Or after would you like to swap over?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. We need that to be, that's need to make one, guys. We need a bigger ambi bag. 1, 2, 3, 4, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2.
How much step and swap? Okay?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, and 1.
1, 2,
1, 2, 3, 4, 5, 6, 7,
Okay,
8,
sharpen
9,
hands.
10, 11,
Just behind you
13,
there.
14, 15.
1, 2,
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2. Did you get in, Dan? Did you?
Did I get that cannula in?
9, 10, 11,
I got that cannula
13,
in.
14, 15.
1, 2.
So it's all done for 1, 2, 3, 4, 5, 6, 7, 8, 9, 10,
Guys,
11,
just
12,
hold on.
13.
I'll go with that, guys.
1, 2. Can we just feel for pulse?
Do I feel a pulse? No pulse.
Keep
Okay.
going. Back in CPR. 2, 3, 4. We're in PEA. Can we get to the adrenaline, please?
12, 13,
The temperature is 28.
17, 18.
Okay.
Sorry, I was 15.
Keep going. 1,
2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 13,
Okay,
14,
right, guys,
15.
it's back
1,
pH 6.91.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1.
And do we have glucose? 1, 2, 3, 4, 5. Do we have glucose in us?
Glucose on the down to 6.
6. Great.
Do you want to know any more results?
1 or 2.
1, 2, 3, 4. And the electrolytes? 8, 9, 10.
So sodium is 132, potassium is 5, chloride is 111, lactate is 12, creatinine is 40.
Did anybody, we called anesthetics, is anesthetics
Yeah, you
here?
wouldn't mind taking over? Yeah.
And can somebody get back on the chest, please?
Fluids,
3, 4.
have we got 2 bolus? Do we have warm
Somebody
fluid?
call
Yes.
anesthetics,
So
please?
we can get 20 mils per kilogram. Right, so he's 6 years of age, we need a Breslow chart.
Top of the board here.
Delay.
After this, then we will swap and I'll give you chest compressions if you put the tube in. Will you do that?
12, 13, 14.
15,
I
1,
will need an assistant.
2. Okay, I'm going to go back on the chest. You do the airway now. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12,
There's Breslow.
15.
And orange on the Breslow chart, so it's fluids.
Warm fluids are ongoing.
We need 530 mils.
5, 6, 7, 8, 9, 10, 11.
So we get that quickly over 5 to 10 minutes.
Yes, if you want. The next time then.
Okay, and I think we need a
2, 3, 4,
second line as well.
5,
I'm
6,
gonna need
7, 8,
assistance for the
9, 10,
airway.
11, 12, 13, 14, 15.
What do you need?
I need a size 2 blade.
Okay.
Macintosh.
Guys, we've got a rhythm change here. Can we feel for a
Okay.
pulse? Feel for a pulse. Do we feel
That looks
anything?
like VF.
That's VF.
Yeah.
Do we feel the
shall
pulse?
we-
Okay, so then you put the pads on and shot, please. Okay?
Okay, let's keep
Keep going,
compressing.
keep
forward.
going. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1,
Just take them.
2,
From here.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
One.
Thank you. So
Two.
we're
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2,
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1, 2,
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
1,
so we give shock.
2,
What's his weight? 1,
And
2,
he's
4 kilo.
Esther.
1, 2, 3,
So
4,
his
5,
orange
6,
drawing,
7,
it was
10, 11, 12, 13, 14,
he was
15.
red, wasn't he?
1,
Orange.
2,
1, 2, 3, 4, 5, 6, 7, 8,
Oh,
9,
sorry.
10,
Sorry.
11,
Yeah.
12, 13,
So
14,
it's
15.
24 kilos, so
Two.
so 2
One,
kilos per kilo first,
two,
so 24 to
four,
48, so we're 50.
8
By
kilos.
pounds, it's 2, if we're doing
17, 18, 19, 20.
And
Sorry.
so
1,
we,
I can take over
Can I
the
use this up?
if you want.
Yeah.
Okay, you take over
can
the
you turn it on?
questions.
Yeah.
So APLS is 4 per kilo. I think 50 is enough water for a period of time. Will we just go straight in for 4
yeah,
kilos?
fair enough. Yeah, that's
So
reasonable.
4 by 24 is
It's
what?
going to be 96, so 100.
96. So start up to 100.
So
Anyway, you can this.
it's on now.
Okay.
So you've switched it on.
1,
Okay.
to
Yeah.
change it to a different
1,
spring.
2, 3, 4, 5, 6, 7.
Are we ready to be charged?
Yeah.
Can I charge?
Yeah, you
200.
can.
1,
Okay.
Yeah.
So guys,
I'm
gonna,
clear, you're clear.
Yeah,
Everybody
shot.
stand back and clear. We're
Okay,
going to deliver.
oxygen
Shot
off.
off, oxygen off.
and I'm going to minister
Shock delivered. Back on the chest, please.
okay, oxygen on.
2, 3, 4,
Now, can
5.
somebody get some equipment to help Dan with secure tracking tube airway?
1,
Yeah, we won't
2.
do this.
So can we get a ring and what size of tube do you want Dan?
I want to release 5, agent 4 plus 4.
So we have an EQ tube.
So, agent 4 plus 4.
It's a 5 and 5.5.
Yeah, let's go 5 cup.
Okay.
Sorry, I'm just going to
You're going to CPR, please.
1, 2, 3, 4,
1, 2. And what are we thinking? We're thinking hypothermia.
So I think we need to look at the H's and T's. Hypothermia, temperature was 24 degrees. So
I'm
I'm
going to hearing the scope blade.
Could we also get big fluid to be warmed in? Could we maybe catheterize them and irrigate the bladder and warm them up that way as well?
Yeah.
We have to get the temperature up. Have we got a rectal thermometer in situ? Is it or just a maxillary temperature?
I have one here, yeah.
Rectal,
Straight blade.
A curved blade 2.
Could we get a rectal thermometer,
2.
Tracy?
Yeah, go.
Okay, you've got the thermometer in.
The temperature is now reading 33.5. The temperature is now reading 33.5.
Okay, so we have delivered one round of shots. Can we?
Is there a lingus?
You can take one of the boxes.
Okay, guys, we've rhythm change. We need to check for the pulse. Okay, after the next set of CPR, just let me know.
50, yeah.
Can we feel for a pulse?
We have a pulse.
No pulse.
Back in CPR.
Do you want me to take over the pressure?
The temp is 33.4, which we need to get some adrenaline now as well.
I'm happy for you to progress. Yeah.
Okay, guys, I'm just going to update you. We've come out of EFib and keep going CPR, and we're going to do that to get an airway. Then after that, then we're going to give some adrenaline. We're into bradycardia, our heart rate of 14 no pulse. We're hitting EA. Okay, so we need to get some adrenaline drawn up as well, but keep going, get the airway clear. Keep going. Can we get some more help? Can we get another pair of hands? Can we get another pair of hands to get some adrenaline?
I have adrenaline here and adrenaline. Just let me know how much you want.
Okay, so 0.1 per kilo.
Okay.
1 in 10,000.
Unfortunately, there's another research going on next door, so there's no extra pair of hands.
Okay, alright, thanks. Okay. Okay.
So Tracy needs 20 kilos.
How are you guys doing there? Have you got the chest rise?
Yeah, I'm getting chest rides and I'm bagging. We're just going to get a tube in.
Okay.
We're going to put a tube.
So he is
4 kilos, so
he is
given
orange,
1
isn't he?
kilo, 1 in 10,000.
Okay, yeah.
Yeah, happy with that.
So 2.7 mils.
Perfect.
Yeah, 0.1 per milligram.
Come into your side.
Okay, we go
Wait.
give it now.
From
Can you
there.
please get straight away?
Adrenaline given, flush given after.
Okay. I'm trying to
You have a
get
scribe?
Compressions
Do you have a
going.
scribe? Can you write
Do you
it
have a
down?
scribe?
Yep, the scribe has been here, the scribe has been writing
Okay, so
everything
then
down.
it's just given on the flush afterwards, please.
Perfect.
Keep going, CPR guys.
Bolus gone through. Do you want another bolus?
Can we get a bolus of fluids, another 10 per kilo, 240 mils, or 250 mils, if you want to say a little warm, but put it warmed up as well. Have we got the fluid for the bladder as well, to irrigate the bladder and warm them up?
Okay, the tube is in.
Okay, great plan. So the tube is in, and the
So we're
CO2
gonna keep-
detector has gone orange.
Compression is going uninterrupted.
Great.
We could get a nasogastric down just to decompress the
Okay,
stomach as
I'll
well.
get Tracy to do
Now,
that.
do you want
Yeah,
to
that's fine.
Yeah. Can we listen? Elaine, can you
Nice
listen?
one,
Would you
Both
happy to
sides,
keep
yeah.
dragging?
Okay, and we've got air
So
entry
tell us
both
the
sides.
Okay.
Do you have air entry? Good air entry on both
I
sides?
have crackles, but there is air and treble sides.
Equal.
Okay, keep
Oh my
going.
god, my son! Oh my god!
Okay.
Is he okay? Is he okay? Oh
Just
no! Was he okay? What's happening?
We're looking after him
No,
at the moment.
Elaine,
Okay,
yeah.
we have him
H's and
intubated,
T's.
we
He's
give
a
him oxygen,
coma.
and we give
I
him
think we should
medication.
consider
Okay,
We
now
have a
that
little bit of work to do. You're more than welcome to stay in the room, but we might get you to stand over here.
Oh god!
Marcus, would you take care of this lady?
Sure.
Have a cup of tea.
Hello, hi, hi,
And we'll
hi, Mom,
in
hi.
terms of our H.
Hi.
Marcus is going to chat to you just about having around our history. We'll do it in 2 minutes.
Okay,
In
yeah.
terms of fluids, we've given a 20 mils per kilo of warm
We'll give
fluids.
one a second bolus of fluids.
So H and T, so we've got our hypoxia, our fluids, and we're for hypothermia, we're warming on bladder and
fluids.
stomach. Warm
Hypothermia,
fluids. Hypoclemia, his potassium I think was
Potassium,
normal on a gas.
sodium,
Is that
sugar, any of
so the
those.
case, and the sugar was normal.
This is the second EEG.
We've another
That's the repeat one.
So second BBG, pH come up to 7, his PCO2 is 10, sodium 132, potassium 4.9, chloride 110, potassium 1.5 ionized, and his glucose is low. Okay, so we need to give him a bolus of glucose. So can we give him
2 mils.
dextrose 10%, no problem, 2 mils per kilo, so 24, say around say 50 mils.
50 mils, yeah.
That's fine. Yeah, I'll get that.
As a rapid bolus.
Do we need
Then,
portable x-rays now?
acids, so I suppose his pH is low, but we're giving him fluids and
So
oxygen.
hypoxia we're giving him oxygen, he's been
Yeah.
intubated, he doesn't have a low sodium, he doesn't have a low potassium, he doesn't
Yeah.
have a low calcium, he has low sugar, we're giving him glucose now in a moment. Hypothermia then, his temperature's come up but we're irrigating his bladder, he's warming his fluids. We've got the warm blankets, the bear huggers on him, okay? He's had 1 out of adrenaline, so we need to go back to, John, you okay there?
Yeah, I could do a bedside ultrasound to have a look for kind of tension and temperature to get them out of the way.
Okay, well, why don't you do
Because
that
he's
and I'll
in
take
trouble.
over from the
You
chest
wanna
here.
take
Yeah, I'll
over?
take
Yeah.
from the chest here. It's actually been 3
Should we
minutes
do
since
a
we gave
rhythm-
the
rhythm
adrenaline,
check?
we need to do a rhythm check and a
Yeah.
pulse.
Okay, so
Let's do a rhythm check.
off the chest. And what we have is the third heart rate. We've
Has he got a pulse?
heart rate of 41.
Has he got a
Has
pulse?
he got a pulse? He has a pulse.
Okay,
Oh my
good.
God, keep going.
He has a pulse?
He has a pulse.
He has a pulse.
Okay.
He has a pulse? Good.
Please.
Okay, let's
Okay.
do an
Heart
A2E
rate
assessment.
41.
I can do an A2E assessment if you'd like.
Yeah, sure. A what
An
assessment?
A2E assessment.
Oh, yeah, okay,
if
yeah.
you've got right.
Okay.
Okay, great. So I don't think we need to.
You happy to stop for that?
Yeah,
Okay.
if you've got a
Heart
pulse.
rate's only 41.
Yeah,
Oh, okay.
40. Yeah, so
Good point.
he's not conscious or
He's
anything
not
like that.
conscious, you need to
Good
keep
point.
going.
Yeah.
Okay.
1, 2, 3.
Um,
And keep going.
Do
So-
we need a portable X-ray? Just if he's a...
Yeah, we should
And
get
is he due
get
for
them
another
on.
dose of
ring
adrenaline?
X-rays?
then?
Yeah.
Okay.
Okay.
Can we get another dose of adrenaline in?
Yeah.
Same one, Tracy, 2.7
Same
mils, the
dose,
one in
yeah,
10,000.
no problem.
Yeah.
So, do we have an ultrasound available?
Yes, we do.
Huh?
Josh, give it
Yeah, so I'd
afterwards.
like to do a bedside ultrasound, in particular looking for tension pneumothorax and tamponade.
You don't see either.
You don't see either. Okay, and,
There's
is there,
non-sliding.
and there's cardiac activity on the ultrasound?
There is, yeah.
There is
yeah,
cardiac
yeah,
activity.
And you do see some
Alright.
B lines as well.
Okay, all right. Did you hear that? So no tension, no tamponade.
Yeah.
There is cardiac activity, and there's B line suggestive of kind of submersion type injury.
Injury, yeah. Okay.
Alright. So the T's are toxins and thrombosis.
Can I
which
suggest
is
that we
maybe-
talk to cardiology in Crumlin and tell them that we have a return to spontaneous circulation in a 6-year-old drowned submerged child. We've given 2 lots of adrenaline, we have a bradycardia, and see if they suggest putting him on some kind of an infusion or where we go from here.
Yeah.
I'm kind of beyond my limits of where I can go now.
Yeah, absolutely.
And we need to get their advice.
Yeah.
Somebody
Okay.
just make a phone call.
No problem.
Are you okay to
I'm fine.
Okay. Oh, we're probably at 2 minutes again.
Okay,
so
yeah,
will we do
let's get
another
rhythm check?
rhythm check?
Oh.
So our heart rate is 77. Do I have a pulse? I have a pulse.
Yeah, the pulse.
Okay, super. So
We can stop CP
we've
over 60, but we are a bradycardia, we've got saturations. Okay, so regrouping them back through again. So A, we're intubated, you've got good chest rise, air entry both sides, some crackles, we're going to get a chest x-ray as suggested by Tracy, sat to 99. So airway breathing, C, cardiac, so we've had 2 rounds of adrenaline, ongoing CPR, heart rate is back. But a bradycardia, now it's come up to 78, but we've spoken to Crumlin, they're going to get back
I
to us.
haven't called them because it was just a change of
Fantastic.
clinical
Maybe we
state.
hold on for the moment. Okay. So then we have given 2 boluses of fluids. We have him warmed up. Pupils are the equal reactive to light.
They're sluggish. They're sluggish.
Just sluggish. Okay. And we've irrigated his bladder. We're giving him warm fluids. 2 boluses. Okay. So and we have, these are actually put off. The scissors is really bad. So maybe we try. We probably need to get him up to ICU, don't we? And ring anaesthetics.
But I wonder if we should just complete our now that we do have
Yeah.
MOSC,
Yeah.
and we
Yeah.
want to kind of go into now we can do the A2E assessment.
Yeah, perfect.
Because he's
Primary
a trauma
survey,
patient,
yeah.
a primary survey. So airway, we got a tube in. How
Yeah.
many of the teeth is that? At the lips, that's 21. That's probably a bit dip. And when I listen to his chest, does he have good air entry bilaterally?
He has good air entry here, bilateral creps.
Okay,
Porous
and
creps.
okay. Does he have any bruising or any deformity
He
of
has
the
some
chest?
bruising on the right side of his face.
Of the
Just on the face,
right
yeah,
side
yeah.
of the face. Okay, and when I look at his abdomen, is there any bruising or deformity there? Okay,
Nice
and
and
I'm
soft.
just going to have a look at his pelvis. When I gently squeeze his pelvis laterally, is there any movement?
It's no.
No, it's a stable pelvis. And just having a look at his legs there, is there any long bone deformities or any organ fractures that I can see?
The left ankle looks a bit bruised and a bit funny, but it's not deformed.
Okay, it's not obviously deformed but bruised. Okay, so you might have a not kind of life-threatening injury there.
We
Okay.
need to clear his spine, his spine.
I don't think we'll be able to. Yeah, I think we'll have to image that. I don't think.
Oh no,
can-
we need to get X-rays. Yeah.
Yeah, I think.
And a chest X-ray as well.
Perfect. Great. And when we look at his pupils, they're
They're sluggish, but
sluggish,
reactive.
but equal bilaterally. Okay. All right. And when I have a look, when I was examining his pelvis, does he have any priapism or anything like that? No priapism. Okay. So no evidence of spinal injury.
What's his temperature?
His temperature is now 35.
35. So we need to X-ray his spine, his chest, don't we? And then get him upstairs.
We should probably need to talk to Crumlin again in case he's someone who might need to be in the section and give my ECMO. Because the risk of further cardiac compromise.
Do they do therapeutic hypothermia in drownings anymore?
Not that I know of, but the recommendations were to ECMO
So
centre.
should we just recap again in terms of where we're at?
Yeah. So 6-year-old boy, he's intubated, size 5 tube, good air entry bilaterally, full crackles. It's tied at, what is that with the lips there? Okay, that's airway and breathing, saturations at 99. We probably need to repeat another gas, I'd say, and see where we are in terms of his PCO2.
Great.
Recirculation.
I was going to say recheck his glucose since we chose that, make sure it's effective.
So his circulation then, heart rate is 82. We have, what are the central and peripheral pulses like?
And we can end it there. That's great. Okay. They're
Okay.
well done.
Okay. 1 minute.
just monitor. So that's
So, okay. So the people that are going to debrief would be Jamie and Aoife. Alysha's here too. To let you do the main debrief.
Right. So that was great. How do you guys feel? How do you?
It's tough in the start when you've so few people.
Yeah.
Because you just want, everything as you think of it, done as you think of it. But it's just, how many different monitors do you need done at the same time?
It's very hard if you're trying to do CPR and
that's
one nurse when you're asking her lots and lots of things.
Yeah.
You need lots of help. You really do. At least another 2 or 3 bodies quite quickly to float in and to in reality they would be there putting on the SAF, putting on the BP, putting on the cardiac leads and all of that. It's very hard then, and I think we have a bit of time looking for a bigger mask and a bigger bag as well.
Yeah, was that on purpose?
No,
I thought that was
so part of this simulation has also a human factors to it. So sometimes we are talking about not the right equipment that was given or can't find the right equipment, and the mother was definitely purposeful and take care of. Yeah. So how do you feel then?
yeah. So like that was tricky. I think it felt clunky, a kind of clunky, messy, but not for. I think for any specific. I think it just seemed to be for. It was mainly there was this kind of constant dance of us swapping in and out of roles and and rotating, and as you say, like it was really tricky to it was clunky because it was so tricky to prioritize.
Yeah. Like if you're the leader, you want to stand at the back, but you couldn't have at the start of the
And see, that is reality, because I think when you are, particularly when things like this happen, and you are the person who, theoretically and hypothetically, it's lovely to be able to run the resuscitation and stand at the end of the bed, but in reality, you are a person with a skill set.
Yeah.
And when you don't have a lot of people around, then you have to be doing as well as running.
Yeah.
And I think that's hard, because when you get focused in your own particular area, you become quite blinded and you get tunnel vision and you're not really as aware of what's going on peripherally, so you're relying on that constant communication from others, I think.
Yeah. It's tough as well, I think, in this one, because one of the things that's important probably is to get the wet clothes off them. But once you start that cardiac compressions, it's going to be really hard to step back and go, okay, stop the compressions while we get all these wet clothes off. Yeah. Because while they're on, it's only going to be working against what you're trying to do. But it's kind of hard to prioritise that or get those little things, get them done early on, because they're going to be forgotten.
But they're the basics, I think. Yeah. I think that's what we probably need to get a little bit more fluidly.
But I guess because he was a submersion, trauma, non-shockable rhythm, cardiac arrest that required kind of prolonged resuscitation, and then went into a shockable rhythm, and that required, when you think about your normal ACLS team, of at least 5 people. Really, so it was really when you it was just 3 of you.
It was only 3 of us. It was only 4 of us. It was only 3 of us.
Yeah. And how did it feel for you? Because you were told to do it.
But it's very hard because it's like Tracy get this, Tracy get that, Tracy can get the other, and she's trying to do one thing after another.
The last thing.
Yeah.
I think it highlights the point you really need help, and you need to put that a crash call out early, and you need to mobilise more bodies. And if they're not coming, then call for them again.
And I think it does feel very real in that scenario, because it feels like, even if it only is a couple of minutes that you're waiting for extra hands to come, it feels like a lifetime.
Oh, it did.
You're trying to do everything. And you're like, where are they? I call them, where are, and it does feel like that.
I do, but I thought we did very well with what we had. I think we had a very good rhythm going with the chest compressions and the breaths. We knew that we needed better equipment, but we worked with what we had.
It was really hard to communicate when I think I was counting to 15, but I was trying to say something else. So then I went to 16, 17, and you have to say to me, you've done the 15. The middle, when there's only 2 people, and you had to count. I think it was the same when I was counting the breaths. When it came to my breaths, I was in the middle of asking for something or trying to think of something, and then you have to, that was really
I think it reiterated to me
literally
before I became involved, it was And what is true in these circumstances, the basics are the most important. So until you have extra help, your biggest priority is doing CPR, and just continue to do that until you have extra hands to get everything else.
There's no point putting adrenaline in if you're not doing good chest compressions and you're getting the compressions and pushing down on the coronary arteries and getting oxygen into the lungs. And that's why I keep saying it's back to the basics and the fundamentals. But I think even who was it? Your point and Tracy's point, trying to get the wet clothes off. Like I think we did blunt scissors, but that is reality as well.
Yeah.
That's reality. If that was to happen, this afternoon,
Here as well, because if you're in the peds A&E, you might have a box of scissors, so you can go grab another one if you think that was blunt. Whereas here, you're like,
see, this is like a trailer,
kind of saying, well, I'll pretend it's done, and then that's
Who reads the T-shirt? But I guess when effectively it is a cardiac arrest, so we're talking about kind of traumatic and non-traumatic cardiac arrests, and you probably actually don't know which one this is.
No, because he could have fallen and banged his chest. He could have had
a heart attack.
Yeah.
There something?
Could have had a head injury.
But the H's and T's,
yeah.
but the H's and T's do include all the traumatic causes as well. It's probably just, I guess, the role of chest compression might be different in a traumatic cardiac arrest, and also the likelihood of the kind of obstructive or hemorrhagic causes, kind of hypovolemia or obstructive like tension or tamponade is higher, but you still do exactly the same thing. So I found the H's and T's quite comforting, where the actual differential was quite wide.
The H's and T's are nice actually for consolidating everything, because no matter what happens, you're going to have something happening with your temperature will go down, your electrolytes. It doesn't matter if it's an electrocution or an ingestion or an accident, something will happen to your electrolytes or your temperature, and you need to get them back on track again. And I think all the T's as well is so important, because not alone could you have been drowning, but you may have hit your chest. Like we had a case last year where there was a boy out playing hurling, and his the hard hurley ball slitter hit him in the sternum, and he went into full arrest. So it was just at that very point, the millisecond of the cardiac cycle, it hit him, and he flatlined. And there's a special name for that, commotion cordi. Yeah.
His mother was a practice nurse, and she was on the pitch. She saw him going down, didn't realise it was her own son, and she went over to help, but it was her own son.
But he could simply happen to him. He could hit the bow of the boat or something falling out or something.
And was he okay, that child?
Yes, absolutely.
Very lucky boy.
So the other interesting thing that I thought was just kind of was a good learning point for me, or just kind of something that I'm going to think about was, so I guess this was a hypothermic patient, and how does your arrest changes, kind of how does your management of an arrested patient changes in context of hypothermia? I mean, you were treating his hypothermia and that was working, which was great, but in terms of how does it change what you do with them, and in particular kind of the drugs?
Well, I wanted to give adrenaline, and then Jamie said his temperature is 28, and the APLS guidelines would say you don't give it until you get the temperature up to over 32. That's so I knew then I had to hold on. But yeah.
So that kind of reinforced that with me when we kind of evidence said, oh no, adrenaline, because it's probably the hypothermia rather than anything causing. And what about, so at one point I said to you, so we checked the rhythm and the heart rate was 41, and he had a pulse. And I said to you, like you were about to get back from the chest, I said, oh, like we don't need to start CPR, he's got a pulse. So I just wanted to kind of explore that a little bit, because I think I'm quite used to adults. But I think this is a pediatric patient, so I think that was a really important point. Just what was kind of your thinking there?
The guidelines sort of say give compressions unless they're over 60. If they're under 60, I think you should be conscious.
If they're under 60 and they are unresponsive, even with the pulse, the bradycardia pulse, you have to continue with chest compressions. If they are sitting up in bed and they're responsive, it's completely different. And I was going back with the chest, and he said, no, stop. So I did. And then you jumped in and said, no, we have to keep going with it.
That was great.
Yeah.
I'm just going to ask a couple of questions.
It's hard when you have 3 bosses, I think. And I was very conscious that...
To debrief.
No, I think when I was you have to give chest impressions, but then I thought, God, has Dan learned something from Ilcor recently that I haven't heard about? And it's also, I think, without wanting to... It's nice to be able to, have mutual respect in you coming in, but I think it's just all, what I'm trying to say is, I guess, without
if you know something to be true,
turning around and say showing somebody up or saying, no, Dan, you're completely wrong. We have to continue going with this. So I was just waiting, and I looked at you, and then you said, no, we have to keep going. So I think there's certain ways you can do it.
But I think that's a really important point too, because in resuscitation, you usually have, SHOs, registrars, consultants, possibly interns, and that intern or SHO that sees something that doesn't quite click, or they might notice something nobody else notices. It's important for them to be comfortable enough to speak up. It's a whole team effort in this sort of situation. So regardless of whether it's someone that sort of trumps you skill-wise, you should still have that discussion, because maybe you're right, maybe you're wrong, but it's still a discussion around patient care, and it's important regardless of what your role is or level is. So I think that really demonstrated that well.
Yeah, I think the PALS versus the APLS thing, because it wasn't something I was aware of until yesterday. You sent out the PALS rhythm, which has 2 joules per kilo for the first unit, whereas, and that made me think, because I knew it to be 4, and it was mentioned yesterday on the ward, and so I let them looked, an APLS does say 4 joules, and that was, you've just done, like you're an APLS instructor.
I instruct on PALS and I instruct on APLS, and I get myself into awful bother altogether. So what I just do is I keep it simple. I keep it 4 for both of them.
Well, I tried to look it up last night to see what was the reason that there was a difference, and I couldn't find anything about it.
There isn't, and it's just historical. They would start at the lower voltage many years ago, and then they just increased up. And what you find is that it's usually the second or third higher energy delivery that will try and convert them back. So APLS are 4. It used to be 2, 4, 4, but it's just 4.
And it now seems to say you can go up to 10 joules with sequential ones in one of the algorithms as well. So it says start with 2, 4, repeat, can go up to 10 joules per kilo, which again I've never
gone up to 10 joules myself, to be honest. But what they normally would know, what we take to the APLS is you give, so you've got a shock of a rhythm. You give 4 joules per kilo, 4 joules per kilo, 4 joules per kilo, and after your third one, then you come in with your amiodarone and your adrenaline and your amiodarone, and then you go into 4 joules per kilo, which is number 4. 4 joules per kilo, which is your number 5, and after the 5th one you do adrenaline and amiodarone again, and then you're going into your 6th one is 4 joules per kilo. I've never gone up to 10. I must look that up. But that's the only time we ever bring the medication into the shock level 1. But we usually keep going with the electricity.
Quickly, just to consolidate my knowledge about so if the patient is bradycardic, they have a pulse, but they have no signs of life, you continue. They're below 60, you continue CPR. What is there an age group? So, like, at what age does that hold until? Like, if they were 15, would you, like, is there an age group?
Probably under 16.
Under 16.
Yeah.
Sure. Perfect.
And that's the point where I said I'd step in and I would talk to Crumlin, because I reached a point of I didn't know what to do. And sometimes the same with SVTs. You've done all you can, and then you just need that little bit of advice for ongoing infusions, or exactly. Because there's certain things I could think of rolling out, but I wouldn't be confident or competent in saying that I could do it, and I think I often get that second opinion from them. Again, similarly, we had a 6-year-old who was a water park boy the previous day and came in very confused, acutely confused. And he was, you remember him, Tracy, he bradycardia, like his heart rate was 35 to 40, but difference was he was sitting up in the bed, he was chatting to me. But this guy isn't, and that's what the APLS would say. If you've got heart rate under 60 and there are no signs of life, but they're not responding, so you keep continuing on with that.
That's why I had said, because you had said to Dr. Ryan, stop, that we have a heart rate, and I was like, the heart rate's only 41 though.
Yeah, that's
and then you went back on the chest again.
Well, that's what Elaine said. No, heart rate's under 60. We need to keep, and he's not responsive. We need to come in again. And I went, there's nothing new that I have missed here.
And it's nice to kind of demonstrate different skill sets and backgrounds, and like as Jamie said, that open communication is important.
See, what I realized here watching this sim, right, is that how usually when we do simulations and then we have research and we're also thinking about who's the team leader, So I just want to explore a little bit from here. So initially we had Dr. Ryan and Dr. Reade here. So now obviously both of you are consultants, so it's not, different, levels. But at that time in the beginning, who did you think was leading, or do you think it was very much shared?
I think we said me, but I think Echo, you're much better. I suppose I said at the start, could we get help? But really what needed to be said was call the crash beef, and Echo, you kind of clarified that, which I think was a good thing. But I think probably from there you were... I think it was shared.
Yeah.
Yeah.
It definitely did seem. It definitely did
shared.
seem like it. Yeah, because you see, yeah. All right. And then when Dan came in after, right? How did that feel with an extra hand coming in?
My God!
Yeah.
Relief to
Just
be
to have
honest.
extra
I
hands.
know it's the same, but relief, just an extra pair of hands.
Yeah.
Just to help out, and also knowing that he's an ED consultant, he's bringing a different skill set with him, and I felt that probably he could get an airway, or if there was something trauma-wise, then he was going to bring that element that I wouldn't be expert in. But I felt it was lovely. I thought it was lovely having Dan there, but I then once Dan came in, I felt that the leadership changed from time to time, and it was almost like little icebergs kind of floating in the water, depending on what people were doing. Like I stood back very much, you took over the airway and you were running that, and then you were doing the adrenaline, and then I went on with chest compressions. But I think we sort of, I felt we segued very nicely between us. That's just my own impression.
Okay.
But I thought it was interesting because we had 4 people here. It wasn't until we had a 4th person that we had any chance of getting an IV line, which is incredible. Like, you're in a hospital and actually you're doing the same as what's done in the back of the ambulance. Like, that's... but that it is the reality of it. But you need it just the amount of hands that you need in reality, and it was kind of, you're stuck, you can't really go any further until you have the line, because you don't know the gas, you don't know the glucose. So we probably could have gotten a finger stick, but all that is
and Tracy, you being the nurse in this thing, you see, how did you feel? Because you were in the sim, you were in the whole, you were in the whole thing. But then you were also the person that probably would have kind of like a bird's eye view over that from the inside. How did you feel?
I thought they did very well, considering trauma isn't number 1 for these guys. Like, it's Dan's bread and butter. But I thought the 2 did very well at the start, like coming in, starting the steps, doing the CPR, all of that.
Very quick,
and then calling for help straight away. So they did, and we put out the 2-2. You had put out the 2-2-2 leap. And it was great, and you as you were saying, mutual respect, you very good mutual respect for both of you and for everybody involved. It's very difficult when it's a trauma, it's not your first line, and I thought all of you did very well.
Very good.
Dan wasn't bad either. I have to say you were fantastic.
Yeah.
And you'd know that you were a most fantastic paediatric nurse, because I found that you ducked and weaved and you had anticipated what we were looking for. And all of a sudden it came, and you very much knew.
And you were calm.
You were very calm. Yeah. But you know what the steps.
If I'm not calm in all this, there's something.
I really thought Tracy was very good in anticipating what we were going to need next and having everything there for us.
I think an experienced nurse definitely does help in a resuscitation, doesn't it? Yeah.
Let's make or break.
I thought you kind of saying, chest x-ray, because no one had said a chest x-ray, and I was like, portable chest x-ray, because we didn't even, so no one mentioned it, because they were just trying to get that anyway.
So in the amount of the purposeful things that we put in this time, so the mask was an accidental purposeful thing, which I think worked well, because you noted that was the wrong mask, that was the wrong bag to actually use, and Dr. Ryan adequately kept saying we need a bigger mask, so I think that's good. For this sim, we actually had a wet t-shirt on under under the jacket. Yeah, did you get surprised when you actually felt it?
I did. Wow, they take this to a whole new level.
So we've actually done that this time. You've actually opened up the jacket and felt it and said, let's cut the shirt.
That's the other thing that actually kind of dawned on me after, because I think I came in for the compressions when the pads were on, we were given the shock, and I thought, we haven't dried the chest. We have a wet t-shirt on, we haven't dried his chest, or we're given a shock. So I suppose it's another learning point that it'll stick in your mind the next time you come across it.
Dry chest, alright. And the second thing, the third one actually was the mother. I think that was very quick. You know how you handle the mother?
I know, but it was probably necessary though in the situation because it was so hands-on and there wasn't a lot of people and he was still very acutely unwell. I thought it was fair enough that you'd put the mum sitting down and assign someone to look after the mum and kind of talk her through things because you were so needed that you didn't have time really to stand back and explain.
I have when I do with parents that fast. I think it's really important for them to be there. I think it's really, really important. And the same for neonatal resuscitations because they will also questions afterwards. And I think it's important for them to see who the team was and that everything was done for their child in the event that it is a tragic outcome and there's no return to spontaneous circulation. And I think sitting in a room on their own, then they will just climb the wall. So I just mobilise them away from the area and just get them to sit with somebody so they can directly see, but also somebody there to take a collateral history from them and get them a cup of tea or something. But I move them very fast because sometimes they can actually be on top of the bed.
They're obstructing people running around.
And a very quick reaction there. It was just boom. That's wow. Yeah. That's very quick. Very quick. Reaction time up there. Yeah. Okay. Yeah. All right. So we close it up.
Thanks, guys. Dan, do you have anything you want to say?
No, very happy.
I do. Happy Christmas, everyone.
Happy Christmas.